You are sitting on the toilet. You have been sitting there for a while now. Not because you want to be, because you have no choice. Your body is telling you something needs to come out. That pressure, that fullness, that deep, uncomfortable weight sitting right at the base of your belly, it is undeniable. So you sit, and you push, and you wait. Nothing. You shift your position, try again, still nothing. You take a deep breath and bear down harder, gripping the sides of the seat, jaw tight, face red. And after all of that effort, maybe a tiny fragment passes, the size of a pebble, and that is it. The rest is still in there, stuck, immovable. And now the pain has shifted from uncomfortable to genuinely alarming. If you are watching this right now and that scene hit uncomfortably close to home, I want you to stop everything else you are doing and stay with me for the next few minutes. Because what you are experiencing is not just constipation. It is something more specific, more serious, and more treatable than most people realize. And by the time this video ends, you are going to know exactly what is happening inside your body, exactly why it happened, and exactly what to do about it step by step, starting today. My name is Dr. Alex, and today we are talking about something that millions of people, especially adults over the age of 60, deal with in private, in silence, and often in real pain. Hard stool that is physically trapped inside the rectum, and how to actually get it out safely, quickly, and without making things dramatically worse. Before we go any further, I want to hear from you. Drop your city or country in the comments right now. It takes 2 seconds, and it genuinely helps me understand who I'm talking to and who I can help. All right, let's get into it. Let me start by telling you what is actually happening inside your body right now, because most people have no idea, and understanding the problem is half of solving it. Your large intestine is roughly 5 feet long. Its primary job is to absorb water from whatever waste passes through it, and it is exceptionally good at that job. Brilliantly efficient, actually. Under normal circumstances, stool moves through at a healthy pace, retains enough moisture to stay soft and manageable, and exits the body without drama. But when stool slows down, and there are many reasons it slows down, which we will get to, your intestine does not get the signal to stop pulling out moisture. It just keeps going. Hour after hour, day after day, your body keeps extracting water from that stool. And what began as soft, pliable waste gradually transforms into something with the consistency and density of hardened clay. Now imagine trying to pass a chunk of hardened clay through a narrow muscular tube. It does not slide, it does not compress, it wedges. And the harder you strain and push, the more you are actually compressing it tighter against the rectal wall rather than moving it forward. That is the exact mechanical situation happening inside your lower digestive tract right now. This condition is called fecal impaction. And according to research published through the National Institutes of Health, it is one of the most common and most under-addressed gastrointestinal problems among older adults, particularly those over 60, those with limited mobility, and those on certain long-term medications. It is not rare, it is not unusual, and most importantly, it is absolutely not your fault. Here is something that almost nobody tells older adults. After the age of 60, several things happen simultaneously in your body that dramatically increase the risk of this exact situation. Intestinal muscle contractions naturally slow down with age. The thirst reflex weakens, so you can be chronically dehydrated without feeling thirsty at all. Pain signals from the gut become less reliable, meaning the urgency warnings that would normally prompt action arrive late or not at all. And if you are on any of the commonly prescribed medications for blood pressure, pain, depression, or bone health, there is a very real chance those medications are significantly slowing your digestive system without anyone ever warning you about it. So if you are sitting here wondering how this happened to you, the answer is this. It is a convergence of biological changes, medication effects, and a digestive system that simply did not come with a proper user manual for the second half of life. The blame does not belong to you. Now I want to spend a moment on something genuinely important, because the symptoms of hard trap stool are misleading in ways that cause people to take exactly the wrong action. The first confusing symptom is liquid discharge that looks like diarrhea. Stay with me here because this one sends people dangerously in the wrong direction. You might be thinking right now, but I cannot have a blockage. I actually have loose movements. Here is the truth that most people never learn. When a large, hardened mass of stool completely blocks the lower rectal passage, the softer, newer waste coming down from higher up in the colon has nowhere to go. So it does the only thing it can. It seeps around the edges of that solid blockage and leaks out as watery liquid. This is called overflow diarrhea or paradoxical diarrhea. And the danger is this: people reach for anti-diarrheal medication, and those medications, the ones designed to stop intestinal movement, are absolutely the worst thing you can take in this situation. They do not just stop the liquid output, they slow your entire digestive system, allowing the impacted stool to continue hardening and growing. If you have loose, watery discharge along with a heavy aching fullness in your lower belly, please do not take anti-diarrheal medication. That is critical. The second misleading symptom is difficulty urinating. This one surprises almost everyone. Your rectum and your bladder are anatomical neighbors. They share a tightly confined pelvic space. When your rectum is stretched and distended with a large hardened mass, it physically presses against the bladder from behind. This can partially compress the urethra, making urination difficult, painful, or nearly impossible. If you are experiencing an unexplained urinary problem alongside any bowel irregularity, that combination is not a coincidence. The third symptom that gets missed is lower back pain. A deep, dull, nonspecific aching in the lumbar region that feels completely disconnected from your bowel. Many people assume a pulled muscle. Many assume arthritis flaring up. But when rectal pressure builds significantly, it radiates outward, into the lower back, into the hips, sometimes down into the thighs. Unexplained back discomfort alongside any bowel difficulty is a combination worth taking seriously. And the fourth symptom, particularly relevant for older adults, is sudden mild confusion or unusual agitation. This sounds unrelated, I know, but there is solid clinical evidence showing that in seniors, a significant bowel obstruction can contribute to what looks like a cognitive episode: disorientation, mental fog, unusual irritability. The body is under significant systemic physical stress, and in older adults, that stress can manifest in ways that look neurological rather than digestive. If an elderly person in your life seems suddenly mentally off without obvious cause, their bowel status deserves consideration as a contributing factor. If this is the kind of information that no one has ever laid out clearly for you before, hit subscribe right now, because there is a lot more where this came from, and you deserve to understand your own body this clearly. Now let me be completely honest with you about what happens if this is left unaddressed, because you deserve the truth delivered straight, not softened into something that loses its urgency. An untreated fecal impaction does not simply sit there indefinitely. It progresses. The intestinal wall, which is living muscular tissue, becomes stretched beyond its functional capacity. Blood supply to that stretched tissue begins to diminish. The muscle begins to lose its ability to contract at all. Higher sections of the colon become involved. Nausea and vomiting begin. Abdominal distension becomes visible. And in the most severe cases, cases that started as exactly what you are experiencing right now, the intestinal wall tears. When that happens, the contents of the bowel spill into the sterile abdominal cavity, causing a rapidly progressing and life-threatening infection called peritonitis. I am not telling you this to frighten you. I am telling you this because the window between manageable and critical is narrower than most people assume. And I want you to take the right action tonight, not next week. So here are the emergency signals that mean you need to stop watching this video and go to the emergency room right now. A rigid, board-hard abdomen that is tender to the touch. A fever above 101 degrees Fahrenheit. Constant, worsening abdominal pain. Not crampy and intermittent, but steady and escalating. A complete inability to pass any gas at all. Vomiting that will not stop. Or a sudden drop in blood pressure with confusion and cold, clammy skin. Those are not wait-and-see symptoms. Those are go-right-now symptoms. If you do not have those emergency signals, keep watching, because what I am about to walk you through is a clear, clinically sound protocol you can begin tonight. Step 1. Stop straining. Right now, stop completely. I know that sounds counterintuitive. Every instinct tells you to push harder. But here is the reality. Not once in the history of human digestion has forceful straining dislodged a hardened fecal impaction. What it does do is dramatically increase intra-abdominal pressure, irritate already inflamed rectal tissue, and create real risk of hemorrhoids or small rectal tears. Straining will not help you. It will hurt you. We are done with that approach. Step 2. Lubrication from the inside. glycerin suppositories. Your first and most effective at-home intervention is adult glycerin suppositories. These are available over the counter at any pharmacy without a prescription. They are inexpensive, safe, and when used correctly, genuinely effective. Here is the piece of information that most people do not know and that makes the critical difference. For a significant hardened impaction in an adult, a single suppository is almost never sufficient. Current clinical practice for rectal impaction in adults calls for using 2 to 3 suppositories simultaneously. One alone simply cannot generate enough lubricant to soften a large dehydrated mass. You need volume. Here is exactly how to do this correctly. Do not stand up and do not sit on the toilet. Lie down on your left side. This specific position, clinicians call it the left lateral decubitus position, aligns your sigmoid colon and rectum in a way that uses gravity as an assistant rather than an opponent. It also takes direct pressure off the rectal area. Before insertion, apply a generous coating of water-based lubricant to each suppository. Your rectal tissue is already irritated and inflamed. Dryness at this stage causes pain and makes everything harder. Gently but firmly insert all 2 to 3 suppositories as deeply as you comfortably can. You want them positioned up against or alongside the hardened mass itself, not sitting near the entrance where they will simply fall out before they can work. Then do the hardest thing of all. Lie completely still. You must hold this position for a minimum of 30 minutes, ideally 45 minutes. The glycerin needs time to melt at body temperature, disperse fully, and penetrate the outer surface of the impacted mass. It also needs time to stimulate the rectal wall to produce its own natural secretions. If you jump up and rush to the toilet after 8 minutes, you accomplish nothing except wasting the suppositories. 30 to 45 minutes. Set a timer. Stay down. After that time, rise slowly, go to the bathroom, and allow your body to work without forcing anything. If there is movement, that is a genuinely good sign. If there is not, stay calm. Do not panic and do not strain. Step 3. Rest, warm water, and walk. If the first round produces no movement, give your body a full hour. Stand up, walk gently around your home for 10 to 15 minutes, and drink a full glass of warm water. Warmth actively relaxes intestinal muscle. Walking stimulates what is called peristalsis, the rhythmic wave-like contractions that move waste through your digestive tract. Even gentle walking makes a measurable difference. Then return to the left side position and repeat the suppository process exactly as described. A second round is frequently what finally breaks through. The first application often softens the outer layer of the blockage. The second round reaches the deeper core of the mass. If you are finding real value in this and following along, drop the number 2 in the comments right now. It lets me know you are here and that this is genuinely helping you. Step 4. When home measures are not enough, go in. I want to be completely clear here. If you have completed 2 full rounds of this protocol, waited the appropriate time between each, and there is still no movement, or if you develop any of those emergency symptoms I described earlier, it is time to go to urgent care or the emergency room. This is not defeat. This is the correct and responsible clinical decision. At the hospital, the medical team has access to clinical-grade enemas delivering larger fluid volumes under controlled pressure, capable of reaching far higher into the colon to break apart the mass from above. They have imaging tools. A simple abdominal X-ray takes minutes and can confirm exactly how extensive the blockage is and whether the bowel wall is at risk. In cases where all other interventions have not worked, a specialist will perform what is called manual disimpaction. I want to be transparent about this so it does not catch you off guard. The physician will physically fragment and remove the hardened mass using gloved, lubricated fingers. In cases where the impaction is severe and surrounding tissue is significantly inflamed, this is not done while you are fully awake in a standard exam room. You will be given appropriate sedation so that you feel no pain and your rectal muscles can fully relax. It is a well-established, safe clinical procedure, and the relief that follows, the immediate, dramatic release of pressure, is described by patients as genuinely profound. Now, getting the current blockage out is critical, but if I stopped there, I would be doing you a real disservice. Because if the conditions that created this are not addressed, you will be back in this exact situation probably within weeks. And the second time comes faster than the first, and the third comes faster than the second. So let us talk about how to genuinely protect yourself going forward. Number one, water is not optional. It is the foundation of everything. Your large intestine extracts water from waste as its primary function. If your body does not have enough incoming hydration, there is simply not enough moisture in the waste stream to keep stool soft as it travels. The challenge for adults over 60 is that the thirst reflex genuinely diminishes with age. You can be chronically dehydrated at a cellular level and feel completely fine, with no sense of thirst whatsoever. The practical solution is this: do not wait until you are thirsty. Drink 6 to 8 glasses of water throughout the day. And every morning, before you eat or drink anything else, drink a full glass of water. That single morning glass triggers what is called the gastrocolic reflex, a natural, gentle wave of intestinal movement that is one of the most effective medication-free tools for regular morning bowel movements. Number two, movement directly moves your bowels. Your intestine is muscular tissue that moves waste through rhythmic contractions called peristalsis, and physical movement of your body directly stimulates peristalsis. A 20 to 30-minute walk after meals, even slow, comfortable walking, has been clinically demonstrated to significantly accelerate intestinal transit time. For older adults with mobility limitations, even chair exercises, gentle torso rotations, or seated yoga stretches make a real difference. Prolonged sitting, especially after eating, is one of the most underestimated contributors to constipation in seniors. Number three, review every medication you take with your doctor. This conversation is non-negotiable. Opioid pain relievers, calcium channel blocker blood pressure medications, iron supplements, calcium supplements at high doses, certain antidepressants, diuretics, and antihistamines are all clinically documented to significantly slow intestinal motility. This does not mean stopping your medications. It means having a direct, specific conversation with your physician. Ask them clearly, could any of my current medications be contributing to constipation? And if so, are there alternatives with less impact on my digestive system? Many doctors simply do not raise this unless you do. You need to be the one who brings it up. Number four, be very careful with stimulant laxatives. This one surprises people, so stay with me. Stimulant laxatives, the kind that chemically force the intestine to contract, are useful in genuine short-term situations. But when they become a daily habit, the intestinal muscle begins to depend on that external chemical signal to initiate movement. Over time, without the laxative, it simply does not contract on its own. This is called laxative dependency, and it is far more common in older adults than most people know. If you have been using stimulant laxatives daily for more than 2 to 3 weeks, please speak with your doctor before stopping and work together on rebuilding natural motility through hydration, movement, and dietary changes. Number five, establish a consistent bathroom routine. Your digestive system follows internal circadian rhythms, just like your sleep cycle. The gastrocolic reflex is strongest in the morning, specifically within 30 minutes of waking and within 30 minutes of eating breakfast. Use that window every single day. Go to the bathroom at the same time each morning, whether you feel a strong urge or not. Sit, relax, and give your body 5 to 10 minutes. Over 1 to 3 weeks, your body begins to synchronize with this routine and starts initiating movement on its own schedule. Consistency is the training tool. Number six, your posture on the toilet matters more than you think. The human body was not designed to defecate from a seated position with thighs at a 90-degree angle to the floor. Physiologically, a slightly squatted position, thighs angled upward toward the abdomen, fully relaxes the puborectalis muscle, a sling-like structure that otherwise creates a natural kink in the lower rectum. A simple step stool placed under your feet when you sit on the toilet, raising your knees above hip level, can meaningfully ease the mechanics of evacuation. It sounds almost too simple, but for many older adults with weakened pelvic floor muscles, this one change produces a genuinely dramatic improvement. Before I close today, I want to speak directly to the caregivers watching this. If you are here not for yourself, but for an aging parent, a spouse, a sibling, this part is specifically for you. Fecal impaction is disproportionately common in bedridden or mobility-limited elderly individuals, and the people who often recognize the problem first, or who could if they knew what to watch for, are their caregivers. If the older adult in your care has not had a meaningful bowel movement in 3 or more days, is complaining of abdominal pressure or lower back discomfort, seems unusually uncomfortable, confused, or agitated without obvious explanation, do not assume it will resolve on its own. In frail elderly individuals, the intestinal wall is less resilient. Their ability to communicate the severity of their discomfort may be limited, and the cascade of complications I described can progress more quickly than in a younger, otherwise healthy adult. Proactive steps matter enormously. Offer warm fluids frequently throughout the day. Assist with gentle movement or repositioning. Consider a glycerin suppository at day 2 or 3 of no movement, not day 6. And if there is any doubt at all, contact their physician. A simple abdominal X-ray can confirm the presence and extent of an impaction in minutes. Do not be embarrassed on their behalf. This is a medical reality affecting a significant percentage of elderly adults in both home and care settings. The conversation may feel awkward. The consequences of silence are far worse. Let me leave you with what I most need you to carry out of this conversation today. Hard stool trapped in the rectum is not a minor inconvenience. It is a serious condition that develops gradually, disguises itself with confusing symptoms, and can escalate to dangerous complications if left unaddressed. The warning signs to watch for are persistent rectal heaviness and inability to pass stool, liquid discharge that looks like diarrhea but is actually overflow, difficulty urinating, lower back pain without obvious cause, and in older adults, unexplained confusion or agitation. The at-home response is stop straining immediately, use 2 to 3 adult glycerin suppositories with generous lubrication on your left side, hold the position for 30 to 45 minutes, repeat once if necessary, and if home measures do not produce results, go to urgent care or the emergency room without delay. For the long term, water intake above everything else, daily movement, a medication review with your doctor, avoidance of laxative dependency, a consistent morning bathroom routine, and a simple footstool to improve your posture when you go. Your digestive health is not a small thing. It is deeply connected to your energy, your comfort, your mental clarity, and your quality of life. And it is one of the most consistently overlooked aspects of health after 60, mostly because people feel too embarrassed to talk about it openly. Well, we just talked about it, and I hope you are leaving this conversation feeling clearer, better equipped, and a little less alone in dealing with something that far more people face than you might realize. If this video helped you today, please hit the like button. It genuinely helps this information reach other people who need it. Share it with someone in your life who might be dealing with this quietly. Leave your questions in the comments and I will get to as many as I can. And subscribe to this channel if you want honest, direct health information that respects your intelligence and does not hold back what you actually need to know. Take care of yourself. Drink your water, and I will see you in the next one.